Hypoglycemia is the most serious and troublesome side effect of the treatment of diabetes in the elderly. It's commonly underestimated because the clinical manifestations are unrecognized or wrongly attributed to other pathological conditions such as cerebral ischemia or degenerative disorders. Older people have a lower intensity and more limited perception of the autonomic symptoms of hypoglycemia than their age-matched non-diabetic elderly subjects. The risk of hypoglycemia increases with the duration of diabetes, and an observational, prospective, multi-centre study that was performed over a year in the UK demonstrated that the annual prevalence of severe hypoglycemia associated with sulfonylureas was 7%, which is higher than anticipated, and equivalent to the prevalence of severe hypoglycemia recorded in people with type 2 diabetes who'd been treated with insulin for up to 2 years. The prevalence progressively increased with the duration of insulin therapy for type 2 diabetes. Increasingly stringent glycemic targets advocated in the modern therapy of diabetes mean that patients' carers need to be informed about the symptoms and the effects of hypoglycemia and its emergency management. Both sympathetic and parasympathetic divisions of the autonomic nervous system are activated during hypoglycemia, leading to direct neural stimulation of the end organs via the peripheral autonomic nerves. And the physiological effects are augmented by the secretion of epinephrine from the adrenal medulla. Symptoms of hypoglycemia vary between individuals, and they may also differ in intensity in different situations. The neuroglycopenic symptoms include weakness, drowsiness, poor coordination, dizziness, confusion, lightheadedness, whereas the autonomic symptoms include sweating, shaking, pounding heart and anxiety. Neurological symptoms include unsteadiness, poor coordination, double vision, blurred vision, and slurred speech. The effects of age on the physiological responses to hypoglycemia lead to an alteration in many of the physiological processes. For example, there's mild attenuation of the blood glucose recovery because hepatic glucose production is diminished, and there are modest reductions demonstrable in the counter-regulatory hormonal responses. Although there may be a maximal response to a more severe hypoglycemia. Symptom response is less intense, with altered glycemic threshold and reduced awareness of hypoglycemia. A lower blood glucose is often required to initiate a symptomatic response. Risk factors for hypoglycemia in the elderly include the following: advanced age and fasting. There are 2 major risk factors associated with sulfonylurea-induced hypoglycemia. The increased use of insulin in older people is also compounding this problem. Intercurrent illness leading to reduced calorie intake can lead to severe hypoglycemia. Polypharmacy leading to administrative errors is also a bit of an issue. On administration to hospital, drugs are given regularly and food intake is reduced, leading to hypoglycemia. Alcohol inhibits hepatic gluconeogenesis and impairs the ability to perceive and interpret the symptoms of hypoglycemia. Concomitant endocrine disease, such as pituitary, thyroid, or adrenal disease, can lead to hypoglycemia. Impaired awareness of hypoglycemia becomes more prevalent with increasing duration of diabetes, particularly in type 1 diabetes. This predisposes patients to a much higher risk of severe hypoglycemia compared to people with normal awareness. The prevention of hypoglycemia is achieved by good education on the symptoms of hypoglycemia and the most appropriate early response. The importance of eating regular meals needs to be reinforced. Patients taking insulin should carry a card or other form of identification. Long-acting sulfonylurea agents such as chlorpropamide and glibenclamide should be avoided, favouring the shorter-acting drugs such as glipizide and gliclazide. These should be used at the lowest dose which is effective. Consideration should be given to using anti-diabetic agents that do not cause hypoglycemia, such as the TZDs, gliptins, or GLP-1 agonists. Drug interactions can occur with aspirin, fibrates, sulfonamides, warfarin, trimethoprim, allopurinol, NSAIDs, and alcohol. It's important to provide adequate information on possible interactions to both patients and relatives who may be administering the medications.